Thank you for joining this episode of UAB Medicine's Post-COVID Lunch and Learn series. Today, Dr. Davil Raval, Assistant Professor in the Division of Pulmonary, Allergy, and Critical Care Medicine, will be discussing lung complications after COVID-19 infection. Please submit your questions in the Q&A, and if time allows at the end of today's presentation, Dr. Raval will try to answer as many questions as possible. For those of you new to Zoom, you will find the Q&A button at the bottom of your Zoom video. I will pass this over to Dr. Raval. Dr. Raval.
Thank you, Jennifer, and thank you everyone for joining us today in this post-COVID webinar series. It is my privilege to be here today. I'm going to talk to you guys about what we have learned taking care of COVID patient over the course of last year or so. And I will be focusing mainly on the pulmonary complications with the post-COVID syndrome. So we'll begin with, let's see if I can get this working to the next slide. There you go. Some of you may have already listened to the other talks as a part of this webinar series, and here are some of the more coming in the future. As I said, I'm going to talk about the lung complication of the post-COVID syndrome. So we will cover basically what's COVID-19 and what are the symptoms of it. We'll focus on the respiratory symptoms of acute infection. Then we'll talk about some of the mechanisms of the post-COVID symptoms in the pulmonary disease and how we usually manage them. And then we'll take some question answer depending upon time. So to begin with, COVID-19 is caused by a coronavirus, which is a common group of virus, which is responsible for multiple common cold and other common respiratory illness. The virus which is specifically responsible for causing COVID-19 disease is called SARS-CoV-2, and it is very contagious. And as some of you may have already heard, there is a new variant coming out, which is thought to be even more contagious than the original strain. If we look at the patients presenting with the initial COVID infection, they have constellation of symptoms. And on the right, you can see frequency based on some of the studies, but it varies with some or the other combination of fever, cough, cold, headache, congestion, muscle ache, and GI symptoms. If we specifically look at the respiratory symptoms in early COVID disease, people will have cough, sore throat, runny nose, shortness of breath, pleuritic chest pain, which is basically the pain with deep inhalation or pain with coughing. Some of them will have chest tightness and voice change. Now, some of these symptoms are very common that we see with the common cold and other viral illnesses too. And many of the patients will recover without having any serious complication from the early COVID-19 infection. However, some patients do develop severe complication of the acute disease, and they can either have pneumonia, their oxygen level can drop, they get significantly short of breath, unable to talk, unable to even take deep breaths. And many of these patients end up in the hospital, and the workup can show that they have a blood clot, they could have a diffuse lung injury, what we call in medical terminology ARDS. They can also develop elevated blood pressure in the pulmonary vessel, which can eventually lead to failure of the right side of the heart. And some of these patients end up on the ventilator, some of them just require high flow oxygen. However, after their initial hospital stay, even if they had a severe COVID-19 infection, many of these patients eventually recover and can go back home. And if we look at which patient after their early mild disease will develop a severe pulmonary complication, there are some risk factors that has been identified, but we cannot pinpoint exactly which person will develop the severe disease. But these risk factors, as mentioned here, like COPD or other chronic lung disease, active smoking, obesity, diabetes, high blood pressure, heart disease, immunocompromised status, whether because of cancer, whether because of some immunosuppressive therapy for joint disease or rheumatologic condition or HIV or any other immunodeficiency state, those patients are at risk of developing a severe pulmonary complication. Now, even after developing severe pulmonary complication, some of the patients can recover without having significant post-COVID symptoms. However, patients who had milder disease to begin with, who were able to stay home, can also develop post-COVID symptoms. And if we particularly focus on the pulmonary post-COVID symptoms, so this is how we define them. The acute illness lasts from the onset of the disease to up to the 4 weeks. If they have ongoing symptoms beyond 4 weeks, up to 12 weeks, we call them ongoing symptomatic COVID-19, still not in the post-COVID phase. But beyond 3 months or 12 weeks is where it's defined as the post-COVID symptoms. And these are the patients who either had the symptoms started right at the onset of the disease, or sometimes they had few symptoms to begin with, but then 10, 15, 20 days later, they develop respiratory symptoms, or they develop some of the symptoms which can persist even beyond 12 weeks or 3 months. And we do want to make sure that these symptoms are not explained by their other underlying condition, like their heart condition, blood conditions, lung condition, to call them as a post-COVID syndrome or post-COVID symptoms. So if we look at the post-COVID pulmonary complaints, what we usually see in our clinic is cough, shortness of breath, wheezing, chest tightness, pleuritic pain. As I mentioned before, that's the pain with either deep breathing or coughing on the side of the chest or in the middle of the chest. Some patients, even in the post-COVID phase, have low oxygen level. Many, particularly young female patients, come with the complaint of racing of the heart or heart rate going very fast with minimal activity. They have a voice change and difficulty walking or difficulty doing the routine activity they used to do. So these are some of the common symptoms or common complaints that we see. If we look at the common mechanisms by which patients develop pulmonary symptoms in post-COVID phase, and I have divided them into few categories, and we'll first talk about airway inflammation. So inflammation of your airway or the windpipe is very common after various viral infections. It's not new to COVID. However, we have seen little bit increased severity with the COVID infection. This is when patients have cough, they have wheezing, they have tightness in the chest. They particularly complain of the cough with either talking, taking deep breath, because the inflammation in the windpipe is aggravated by gush of air that goes in when you take a deep breath in. And that's when they start coughing or having chest tightness. This is one of the common complaints that we have seen in the post-COVID patients. And if we look at all the patients that come across our clinic with the airway inflammatory symptoms, we can divide them into 3 groups. One group is patient who never had asthma and did not have any risk factor for asthma. These are the patient what we call post-viral syndrome or reactive airway disease. And these are the patient usually gets better over the course of few weeks to months. Then there is the second group where patient did not have asthma before the onset of COVID, but they did have risk factor for developing asthma, what we call asthma phenotype. This is where they had allergies, they have a lots of sinus symptoms, they have sensitivity to environmental stuff like chemical, perfume, bleach, cigarette smoke, pollen, something like that. And they may have family history of asthma. So this is the second group of patients who have ongoing airway inflammation after COVID, and they may linger little longer than the first group of patients. However, we still do not call them asthma, at least for first few months up to 6 months, and call them reactive airway disease or airway inflammation after viral infection. And the third group of patients is patients who do have asthma, which may or may not be well managed before COVID, but most of the patients do have asthma, which was well managed. They were not needing any inhaler, not needing any treatment. And after the COVID infection, they are having worsening symptoms. And these patients, we do call them asthma, which got aggravated or exacerbated after COVID infection, and they sometimes require even lifelong treatment. So that is the one very common mechanism how patients have ongoing symptoms after COVID infection. The second mechanism is the lung tissue injury. This happens when patient has developed pneumonia after COVID. The pneumonia that happens after COVID infection is usually multifocal or involving various parts of the lung. And most of these patients do recover over time. However, some of these patients develop permanent scarring or scarring, which may or may not be permanent. Now, as the pneumonia's word sound is the infection within the lung, but sometimes as a secondary result of this infection, patient also develop inflammation outside of the air sac, what we call interstitium, or the space between the air space. And that's are the patient who has a more diffuse lung injury, more pronounced lung injury. And depending upon the severity of lung injury, they may need oxygen upon discharge from hospital, or even beyond that for a few months, and sometimes lifelong. The third mechanism by which the lung injury happens is a blood clot. It's not a very common problem, but we do see this in the acute infection phase, or sometimes few weeks to even month later, that COVID does increases the risk of developing a blood clot. And if this blood clot is large enough to block main blood vessel, then only it is associated with the low oxygen level. Small blood clot can go down in the distal end or the periphery of the lung, and usually it does not cause low oxygen level. However, the blood clot within the lung can sometimes cause increased blood pressure within the lung, and that is a second mechanism how patients require oxygen after blood clot or after COVID. The another reason why patients have a pulmonary symptoms or unable to do their activities without getting short of breath is what we call deconditioning, which is not truly related to lung, but it does manifest as lung symptom. And this is caused by poor oral intake during the COVID infection, weakness, unable to get out of bed. And then this get aggravated if patient gets steroid, if they stay in ICU, if they are on ventilator. This all medication and all intervention that we do to improve their outcome can eventually lead to worsening of the deconditioning. We have also seen various patients with the COVID infection have loss of muscle mass and significant weight loss. And that is also in turn is associated with deconditioning. And eventually it makes their shortness of breath worse. They are not able to do things or walk around the house or go outside of the house without getting short of breath. Now, I do want to emphasize that all these complications, all these mechanisms are there, and we have seen various patients, but it is still a small majority of the patients who have a serious complication. Most of them either recover or have a milder degree of complication. So when we see the patient in our post-COVID pulmonary clinic, what are some of the treatment and investigation that we do? So the common workup would include a chest X-ray. We do a breathing test or called pulmonary function test that basically functions how well one can get the air in and how well they can get air out. whether they are able to expand their lung or not as good as they should. Then depending upon these two tests, patient may need a CT scan of the chest to get better look at their lung tissue. We also do very commonly do a 6-minute walk test, which is basically where we check their oxygen level and heart rate during exercise. This may work for some of the patients who are very deconditioned, but some of my patient comes with me who are a marathon runner or half marathon runner before coming. So they may be still able to walk few miles, but nowhere where they used to do before. So for this patient, 6-minute walk test may not be enough. We may need to exercise them more in order to see if they are having any low oxygen or any complications or not. And then we also look at their echocardiogram or heart test, which can tell us if the right side of their heart or the pressure within their lung is elevated or not. Based on the finding of this test as well as the symptoms, some of the common treatment that we use in the post-COVID population includes inhalers. And there are different type of inhalers, but we broadly divide them into two groups. The first group is what we call maintenance inhaler or a daily inhaler. These are the inhalers that we tell our patient to take every day, depending upon the frequency written on the prescription, once or twice a day. But we don't want them to miss a dose or two because they are feeling good. So these are their maintenance inhaler they take every day. And then there are rescue inhaler or emergency inhaler, which they can take on top of their maintenance inhaler, and they can use it few times a day depending upon their need. Now, some patients, because of their age, because of their other diseases, have difficulty holding the inhaler as shown in this cartoon and do the exact set of actions that are needed for the medication to reach to the lung. And in those patients, we can give the same medication that is given with the inhaler, but in a nebulizer form. So it's a liquid medication that will be delivered via mist, and it can go deeper into the lung. And that's what we mean by breathing treatment or a nebulizer. Depending upon patient's oxygen level, they may need supplemental oxygen. And some patients have oxygen need 24 hours a day, but majority of them need only when they exercise, because that's the time when their oxygen drop. However, I do tell this to almost all of my patients that if you have exercise-related oxygen need, then by and large, your oxygen level is going to drop at night. Everybody, even a healthy person, drops their oxygen at night, but only by few points. But if you have a lung disease, whether it's a COVID-related lung disease or any other lung disease, there is a good chance that your oxygen level will drop even further. And because nobody is monitoring it at night, nobody will know that. So that's why if somebody is needing oxygen with activity, we also tell them to use the oxygen at night time too. Now, there are some tests that we can check once they get better to see if they're gonna still need oxygen at night or not. But to begin with, if you are needing it with the activity, it's good to start using it at night also. If patient has a significant inflammation in the lung, then a selected subgroup of patient may require oral steroid like prednisone or dexamethasone that were given to them while they were in hospital, or they may not have needed them. But the oral steroid that we give are going to be in pill, and then sometimes you need it for 3 weeks, sometimes they need it for 4 weeks. But as you may know, that steroid does come with some side effects. So we want to use them judiciously, and many a time if patients are going to require steroid beyond 2 weeks, then they do need some other medication to prevent the side effect of those steroids. And if patients have diabetes or high blood sugar, we do want them to watch their blood sugar closely, because it is possible that they may need to increase their diabetes medication while they are on the steroid. Another thing which has shown to improve the outcomes significantly in the post-COVID pulmonary symptomatic patient is exercise and cardiopulmonary rehab. So our goal is to get patient back to the activity level they used to do before COVID happened. And because of the deconditioning, because of various factors that I mentioned before, many of these patients do not get to that level right away after recovery. So that's why we focus more and more on daily exercise at home. And I tell this to most of my patients. What I mean by daily exercise is something which you do uninterrupted. So doing some chores in the house where you can work for 30 seconds, a minute or two, and then you sit down would not increase your endurance and stamina as much as you can do by doing 5, 10, 15 minutes of continuous exercise. And it could be low intensity, whatever pace you can keep it up with, but then gradually build up on the time and then intensity of that exercise. Some of the patients, we do refer them to cardiopulmonary rehab, which is an outpatient exercise program. The concept or the idea is the same as daily exercise, but here it will be structured, supervised by a nurse and a respiratory therapist, and intensify based on patient's personal tolerance and need. They go as an outpatient 2 to 3 times a week for up to 6 to 8 weeks, depending upon the need. And on other days, they can still continue doing the same level of activity at home. But these two non-medical, non-pharmacological interventions have shown to have a significant improvement in post-COVID symptoms in many of the patients. And then there are some clinical trials going on for patients with fibrosis or scarring of the lung, which not everybody would qualify for, and not everybody actually need to be part of it. But if patient has a severe or worsening fibrosis or scarring in the lung, we do have some clinical trials for those patients. And whenever we come across any patient who qualify for that, we talk to them and give them more details about it. So these are some of the common treatment or common actions that we take in our post-COVID pulmonary clinic. And as I said, many of them may not need any of this treatment. They come, we talk to them, we look at their x-ray, we look at their breathing test, and at the most we give them emergency or rescue inhaler and tell them to exercise and continue to build up their endurance. But some patients, depending upon their lung severity, may need all or some of this treatment. So that's all I have about the post-COVID pulmonary complications. And I'll take some questions now.
Thank you, Dr. Ravel. So question number 1, can COVID-19 cause permanent asthma?
So good question. And as I mentioned in the slide of airway inflammation, we have seen 3 groups of patients who come to us with airway inflammation. And the first and second group were patients who did not have asthma, but had some risk factor, or patient who had never had asthma and no risk factor. Now, if these patients, after treatment of what we call airway inflammation or reactive airway disease for about 6 months or so, if they continue to have symptoms and their breathing test still shows what we call obstruction or difficulty getting the air out, that is when we make the diagnosis of permanent asthma. So yes, there are small group of patients who can develop the permanent asthma after COVID, but we at least wait for 6 months after the initial infection with the treatment to see if their symptoms resolve before making this diagnosis.
Question number 2. I had COVID in January and I still experience a bad cough. How long should I expect to experience this cough?
So cough after COVID is one of the common symptoms that we see in the clinic. If you had a COVID in January, we are talking about June now. So we're still not into 6-month mark. It depends on few factors. One, what is the cause of the cough? The 3 most common cause of chronic cough, which is the cough that has been persistent beyond 12 weeks, is either airway inflammation, acid reflux, or nasal symptoms or allergies. Now, patient can have 1, 2, or 3 of these. And the duration of the cough also depends on whether these symptoms have been treated or not. So without knowing specifics of this, your cough can linger if 1, 2, or 3 of this cause has not been adequately treated. And if you are still having the cough after 5 or 6 months, you should talk to your doctor, and they can certainly help you out there.
Question 3. Why are my allergies worse now and I am getting bronchitis more often?
So this again goes into the rhyme of airway inflammation. Patient who have asthma or patient who have tendency to develop asthma, these are the patients who are more prone to allergies and have more severe response to the same allergens that their colleagues or their family members don't have to. So as your body is recovering from COVID, your airway and your nasal cavity, where the COVID-19 virus initially entered from, still have ongoing inflammation there. And that might be one of the reasons why you are more prone to have allergy-related symptoms and bronchitis. Now, many a times this bronchitis will not respond to antibiotic alone. So we have seen some patients who have a multiple round of antibiotics thinking this is an actual bacteria, but truly it is just an ongoing inflammation. So you do need some medication to sort of dial down this inflammation in your body.
Explain shortness of breath and why some people need oxygen and some do not, along with how to improve stamina.
So shortness of breath and low oxygen, those two are two different symptoms. Let's talk about the low oxygen first, and then we'll talk about shortness of breath. As I discussed earlier in my presentation, the degree of lung tissue injury because of COVID is responsible for how much and if patient is going to need oxygen. And the second reason why patient do need oxygen after the COVID is if they have elevated blood pressure in the right side of their heart. Now, this is irrespective of whether they have underlying lung problem or not. If they have underlying COPD, they have underlying congestive heart failure or some other lung condition, that would be another reason why patient will need oxygen, and severity will vary depending upon this disease. The second part of the question was the shortness of breath. So shortness of breath is a subjective feeling which may or may not be associated with the low oxygen level. And there are few reasons why patients feel short of breath. So one of the reasons is that if they are not able to get enough air into their lung, or what we call restriction, if they take a deep breath and they are not expanding their lung as much as they should, that will make them short of breath. The second reason why people get short of breath is if they are not able to exhale air out, whether it's because of the airway inflammation, whether it's because of COPD. But if you're not able to empty your lung out, then the next breath that you take and the next breath that you take after that, they are going to be difficult, and that's why you're going to feel short of breath. And then the third reason why patient can become short of breath is, as I mentioned before, deconditioning. Because of their steroid use, because of their weakness, because of various reasons, their overall stamina and their overall endurance have gone down, and the same amount of activity they used to do before without any trouble now makes them feel short of breath. So these are the few of the reasons why patients get short of breath. And in order to improve these things, obviously you need to have a treatment for underlying disease if you have any. But beyond that, getting your routine exercise, building your endurance, and using the inhaler, at least the emergency one, if you are having some airway obstruction or difficulty getting out, will help you with those symptoms.
I get out of breath doing simple chores around the house. What medicine or exercise will help this? This patient was on the ventilator for 57 days.
So when you have this severe of a disease to begin with, when you spend 57 days on the ventilator, the body goes through all the factors that I mentioned here in deconditioning, right? You were on ICU, you were on ventilator, you were on steroid, and that, many times when patients are on steroid, they require multiple medications so that their body will let the ventilator take over the breathing and do the job, what we call sedating medication. And all this medication also have effect on your body and your ability to work. So after those prolonged hospital stay, ICU stay, and ventilator, it's gonna take a lot of exercise and lot of endurance building techniques for you to get back to your pre-COVID or pre-hospitalization level of activity. We have seen patients get back to that. So this is not absolutely something that cannot happen, but it's gonna take a lot of patience and a lot of work with the physical therapy and cardiopulmonary rehab. In terms of medicine, it's because without knowing exactly what the underlying process is, there is not any one magic pill that's going to help you get better. That needs to be further evaluated.
If COVID leaves your lungs scarred, is there a chance that interstitial lungs, pulmonary fibrosis, or bronchiectasis cannot get better?
That's a very good question. And, as I said, we have learned about COVID over the course of last year or so. So when in the earlier part of the last year or so, when we were seeing lots and lots of patients hospitalized with COVID, we were worried that we're going to have a very large number of patients show up with permanent damage to the lung and permanent scarring. But fortunately, after seeing various patients into the post-COVID clinic and doing various, combining our all knowledge across the country and across the world, fortunately, it's not that many patients. Most of the patients do get improvement in their bronchiectasis, in their scarring, in their fibrosis. As the lung heal, the lungs try to sort of get back to the normal state. However, there will be a small proportion of patients who may be left with some degree of scarring, which will become permanent. And unfortunately, there is even smaller number of patients who have what we call progressive pulmonary fibrosis or worsening scarring. And these are the patients who require further intervention. So to answer your question, most likely it will heal, but there will be a small percentage of patients who may not heal completely. And as of now, we do not know which group of patients will be improving and which will be not. And that's something we are trying to study further.
How long do these lung complications last? Can reinfection occur while experiencing these?
So we have seen patients coming to our post-COVID clinic having initial COVID infection about a year ago or so. Now, as I mentioned in the earlier of the presentation, they may not have all of these symptoms when they got COVID. Sometimes they got COVID and then some of the pulmonary symptoms started 6 weeks, 8 weeks, even 2 months, 3 months after their initial infection. But we have seen patients who have ongoing symptoms for 6, 8, 12 months. Again, that's a very small group of patients. Most of them get better by 3 to 4 weeks, and if not within few months. But there may be some patients who develop ongoing symptoms for 6, 8, even 12 months. And the second part of the question is that, can I get a repeat COVID infection? And answer is yes. And if you are recovering from an earlier COVID infection and have not completely recovered and end up getting the second COVID infection, that may lead to more complication and more damage. And that is one of the reasons why we strongly recommend every patient who is recovering from COVID infection to still get COVID vaccine, because the immunity that you get from the actual infection may not last that long. And that's why you need the booster with this vaccine so that you don't get COVID infection again.
Okay, how much does diet play in lung complications such as coughing and shortness of breath?
So diet does not have a direct correlation to the lung complication from the coughing and shortness of breath. However, as I mentioned earlier, the three common causes of chronic cough or the cough that goes beyond 12 weeks are asthma or sinus infection or acid reflux. So if somebody is having a chronic cough because of the acid reflux, their diet may need to be modified and may need to be adjusted to avoid excessive acid production. The other subgroup of patient on whom the diet may play some role with the shortness of breath is the patient who has what we call hiatal hernia or who have outpouching of the stomach in the lung cavity. So if these patients have a large meal and their stomach is very full, those patients do get shortness of breath after eating for a few hours up to half a day or a day. And this is another group of patients on whom small frequent meal may help decreasing the shortness of breath. But per se with the lung, there is no direct correlation with that. We do want you to have healthy diet that helps you heal your lung as you are in the process of post-COVID recovery.
What causes your oxygen to dip throughout the day and come right back up multiple times? For instance, if it were to dip into the 80s and recovers within a few seconds.
So the drop in the oxygen saturation depends on your body's demand and supply. All right, so let's say right now I'm sitting here talking to you guys and my body needs X amount of oxygen. But if I start walking or running or jogging, that X becomes double or triple or 4 times than what it's needing right now. Now, if your lungs are healing or if your lungs are diseased, or for that matter, if your heart is diseased or you have a low hemoglobin, all of these reasons, all of this can prevent your oxygen supply to double or triple or quadruple when your need is. And that is why sometimes with activity, your oxygen level will drop. And when either you slow down or you sit down, and that's when the oxygen will come up. The another reason why it can also happen is that in order for your oxygen to be delivered to your hand and leg, where we actually measure the oxygen level, the blood has to reach that part of the body. And heart has to pump in order to go get the blood over there. So even if your lungs are healthy, but your heart is not able to pump enough blood to your hand where you actually put your pulse oximeter, then also you will see sometimes low oxygen, but then as you slow down, it will come up.
So this person's 5 months out from getting COVID pneumonia and they're still having problems getting a deep breath. Will this ever improve?
So without knowing specific details of it, we have seen patients who do have difficulty getting deep breath after COVID, which may last up to 5 months. And then, yes, it can improve. It depends on what is the reason why you are not able to take deep breath, right? If the reason is that you have a significant scarring in your lung, and if this has become permanent scarring, then it may be less likely to completely resolve. But if the reasons are just the inflammation around your rib cage, then as the inflammation goes down, it should get better.
Are the voice changes also caused by inflammation, and is it expected to be permanent despite being treated with a daily steroid inhaler?
So yes and no. There are some cases in which the voice change is secondary to inflammation in the back of your throat or on your voice box. And those are the cases that will improve. But there are also the cases of the voice change that happens secondary to the side effect of steroid. And that is why, at least to all my patients, I tell them that if you're using the inhaled steroid, I want you to thoroughly rinse your mouth afterwards, because in some instances you develop thrush or some infection on your voice box or back of your throat after using steroid, and that can make your voice changes. And then there is a third group of patients who have a voice change because they were on the ventilator, because of the COVID, their voice box is not moving as good as they should. And this group of patients will not get better with the steroid, but they may get better with the voice therapy and seeing ear, nose, and throat doctor for that.
So last question, you discussed earlier patients getting reinfected with COVID. This person would just like to know, how do you define reinfection?
So that's a good question, because it is not so much of a problem now, but in the middle of the pandemic, where the cases were very high, we have had patients who had persistently positive swab for 3 weeks, 4 weeks, 6 weeks, even though their symptoms were gone and they were back to feeling normal, they still have a positive swab. So these are the patients whom we will not call as a reinfection, even though if they had one negative swab, because the result of the swab also depends on the quality of the swab, which side it was taken from, how intensely it was taken from. So if you have symptoms with the COVID and they get better, then if your test comes back positive after a week or so without any symptoms, we will not call it as a reinfection. However, the people who have COVID, they got better, that test is negative, but a month later or a few weeks later, they started having again the second set of symptoms similar to initial presentation or a different sets of COVID symptoms, and they turn test positive. These are the patients whom we will call reinfection.
Thank you, Dr. Ravel. Thank you for joining us. We hope this information has been helpful and informative. To register for other post-COVID Lunch and Learns or to view a recording of today's session along with the Q&A, visit uabmedicine.org/post-COVID. Thank you.
Thank you, everyone.